start the meeting.
Arup sir. Good evening, all of you. Welcome to the 4th edition of our ophthalmology classroom. Today, we have with us our President of the Kerala Society of Ophthalmic Surgeons, Dr. Arup Chakrabarti. Sir, over to you, sir, for introducing this program and taking it forward. Over to you, sir.
Thank you, Gopal, for asking me to be present here for the inauguration, and a warm and hearty welcome to all the delegates. Though Gopal calls it a postgraduate classroom, but the way it has been conducted the last 3 times, it appears to be beneficial to all ophthalmologists. I have viewed some of the programs after the session was over. For those I could not sit through, and they were really master classes and very well presented, very well discussed, and a very well conceived program. Thank you, Gopal, for conceiving this program on behalf of KSOS and running the program with so much of dedication, sincerity, and all that. I think this is going to stand all the postgraduates in good stead. Thank you, Dr. Rohan and Dr. Prakash, for agreeing to spend some time with the postgraduates here. And I would request all the postgraduates to make full use of the opportunity and present well and discuss out your presentations in the presence of these stalwarts. I wish this program all the success. Thank you.
Thank you very much, sir. This is the 4th edition, as I said. The first one began on the glaucoma week with a glaucoma case. And then alternate week, we are having a case presentation, an exam-based case presentation. And the alternate week, we are having an investigation. So we finished visual fields. If you want to see the visual fields, it's already available. And this is the second one, which is the fluorescent angiography. So without any further ado, I will just go and take you through a small, presentation on fluorescent angiography. And, it's a photographic surveillance of the passage of fluorescent through retinal and choroidal circulations. It is described by McLean and Maumini by slit lamp biomicroscopy and ophthalmoscopy, and Novotny and Alvis in 1961 demonstrated photographic documentation as well. So fluorescence is a property of certain molecules to actually emit light energy of longer wavelength when stimulated by lights of shorter wavelength. You know that shorter wavelengths is more energy, and that is absorbed, and then a longer wavelength light is emitted. So that is a fluorescent. And in fluorescent angiography, the absorption spectrum is the blue spectrum, the 480 to 500 nanometers, and emission spectrum is the green spectrum, the 525 to 530 nanometers. So that's the emission. That's the excitation and emission spectrum. Now we have 2 filters. One is a blue filter, which will give only blue light into the retina, and then the other filter is the barrier filter, which will take out only the green light into the fluorescent camera. Characteristics of fluorescent is that it is very non-toxic, it is inexpensive and safe, even in nephropathic individuals, even though coronary angiography is considered a contraindication. Here there is no contraindication. It's an alkaline solution, it's highly fluorescent, and it does not diffuse through the blood retinal barriers. It is contained within the retinal, arterial, and venous system. But the choroidal area, it's completely leaking, and removal from the blood is by liver and kidneys. This is the fluorescent binding in the retinal capillary. It is completely bound within it. It doesn't go out. That is why we can see the vessels very clearly. And in choriocapillaries, it is very, very highly leaky. Procedure is, you require an informed consent because, even death has been reported after a fluorescent angiogram. Usually we use the antecubital vein, 21 gauge needle. We need to inject it rapidly, and 5 ml of 10% sodium fluorescent within 2 seconds, and flush with a normal saline solution. There has been a lot of recommendations and modifications. Some people flush it with hydrocortisone injection or something like that, so that the allergic effects are less. Now, dye transit time, the arm retina circulation time is the injection time to the first time when appearance of the dye occurs in the retina, and that's about 10 to 12 seconds. In young adults and older patients, it's a little delayed, 12 to 15 seconds. there are some hazards, including extravasation, which is causing severe pain, nausea, vomiting, vasovagal attacks, anaphylaxis, etc. We have the outer blood retinal barrier in the inner blood retinal barrier. The outer blood retinal barrier is a tight adhesion between the Bruch's membrane and the overlying retinal pigment epithelium and the zona occludensis, which is connecting each of these retinal pigment epithelium. The inner blood retinal barrier is in the capillaries, in the retinal capillaries, and we have different phases, right from the choroidal phase, arterial phase, arteriovenous, venous, and late phases. So you can see that in the artery, just before the arterial phase starts, you have the choroidal phase where the choroidal flush will be there. And then we have the arterial phase, the arteriovenous, and then the venous, mid-venous, late venous, etc. And finally, the recirculation phase. Some images here. This is an arterial phase. You can see that the arteries are filled with fluorescent, not the veins. And there is already a choroidal flush, which is all around. So after the choroidal flush, you have the arterial phase. This is again another arterial phase. Then veins also start getting fluorescent inside. And initially, there will be a laminar flow. There will be a laminar flow inside. You can see that then we have a mid-venous or early venous or mid-venous phase. After the early venous, we have the mid-venous phase. Here, the venous concentration, the venous intensity of fluorescence is much higher than the arterial intensity. Till this point of time, arteries were more intensely fluorescent. Now veins overtake the arterial fluorescence. And then we go to a late venous or a mid-venous and a late venous phase. And then finally, both arterial fluorescence as well as venous fluorescence comes down, and then you move into a recirculation phase, where it's a very late phase, maybe after 3 to 5 minutes. So the foveal avascular zone is usually dark because of avascularity, blockade of the choroidal fluorescence, because of the increased density of xanthophyll, and RP cells there are quite large, contain more melanin, and maybe multiple layers as well. Now let us go into abnormal fluorescence, which are reduced fluorescence and increased fluorescence. Increased fluorescence is called hyperfluorescence, and reduced fluorescence is called hypofluorescence. These are the two terminologies which are there. Now, first of all, you have to comment on the red free or the color photograph and indicate, whenever you are talking about the angiogram, you have to indicate the phase of the angiogram, indicate any hyper or hypofluorescence, and what happens to this hypo or hyperfluorescence in terms of intensity and area in terms of time. So as time moves on, you should be talking about hyperfluorescence increasing in area, hyperfluorescence increasing or staying stable as intensity. So intensity and area change over time is what we need to look at. Now hyperfluorescence can be divided into pooling, window defect, leakage, and staining. And pooling can be further subdivided into subretinal space and sub-RP space. Let's go into them one by one. Now, this is looking like a pigment epithelial detachment there. There's a potential space there. And you can see in the fluorescent in the earlier frames, there's a venous phase. You can see that it started to get filled up, but you can see over a period of time, it is increasing in intensity. And there's a magnified picture showing an increased intensity actually. So here, the area is remaining constant. The intensity is increasing. It is pooling. And this is in the sub-RP space. Whereas here is a case of central serous retinopathy, a sensorineural detachment here. You can see that the early frames, you can see a leakage coming there, and slowly that leakage is increasing. It's a smokestack leak which is moving up. And then finally, you can see that here is a case where the whole area is pooling. So the whole area here, this much large area is showing a pooling. So this is again another sensorineural detachment, leakage. You can see the ink blot pattern there, and this is an ink blot pattern of leakage. You can see that the intensity as well as the area of the leakage is increasing. Now again, this is a leakage in which you can see the neovascularization in a proliferative diabetic retinopathy. You can see the intense fluorescent leakage here. It increases in intensity as well as area. Here is a case of ischemic optic neuropathy. You can see the increase in the intensity as well as area here. Here we have leakage again. You can see the central macular leakage. Initially it was very less, but you can see it is increasing and increasing further to form a flower petal pattern. and with a disc hyperfluorescence, which is typical of a cystoid macular edema. Now, this is again a choroidal neovascular membrane. You can see the lacy fluorescence in the initial phases, which keeps on increasing, but there are lots of blocked fluorescences around as well. So this is how we will pick up leakage. So increase in intensity as well as area is leakage. Window defect, there will be damages in the retinal pigment epithelium. Like through a window, you are looking through that into the beyond that. So that is how you will pick up a window defect. These are window defects, right? This is again, you can see this is leakage. There are certain times you have capillary, filling defects. So hyperfluorescence, we have blocked fluorescence as well as filling defects. Blocked fluorescence can occur because of pigment like xanthophyll or even hyperplasia of the retinal pigment epithelium or abnormal material like exudate or lipofusion or even blood. And here we have a blocked fluorescence secondary to a subretinal hemorrhage. Why do we call this subretinal hemorrhage? Because the vessels are coursing through on top of the hemorrhage. And you can see two types of subretinal hemorrhages here. One is a sub-RP hemorrhage, which is central, which is more darkish, more blackish, and the more reddish one, which is more subretinal incompetent. You can see here that the blood is below the vessels and it is blocking the choroidal fluorescence. Okay, this is blocking choroidal fluorescence. This is a pre-retinal hemorrhage, which also will block the retinal fluorescence. You can see this. It blocks the retinal vasculature as well. Okay, this blocks the retinal vasculature as well. Here is a case of intra-retinal hemorrhages. In a branched retinal vein occlusion, you can see intense intra-retinal hemorrhages, which also produces blocked fluorescence. But you can see the vessels, it's coursing through the vessels, right? So vessels are some of these are below, some of these are above, right? So these are again blocked fluorescences in multiple pre-retinal hemorrhages. All right, these are blocked fluorescences. So going on and on, you can see that here there is an area where there is a capillary non-perfusion near the optic nerve. There is an area of capillary non-perfusion which is continuously standing there. All right, yeah. I think all people are trying to find me now. Vascular filling defect here. Again, you can see superiorly there is intense capillary non-perfusion. So going on, this is an autofluorescence. You can see a drusen, and this is an autofluorescent image even without a fluorescent, which tells us that this is an autofluorescent material. So this is a brief introduction into fluorescent angiography, which I think I have taken about 10 minutes. And now over to Prakash and Rohan and our postgraduates to go through this fluorescent angiography. The pattern that we will go through would be somebody will present a fluorescent angiogram, and based on that fluorescent angiogram, Rohan and Prakash will ask them questions and we will go forward in that. There is no problem in shying away. This is the way you learn. And obviously all of us make mistakes and learn. And it is always better to make mistakes now rather than make mistakes later in life when you're actually in a responsible position when you are looking at a patient. Over to you, Prakash and Rohan. Let Netra can present the fluorescent, and one by one people can start presenting. Okay.
I'm starting with the first case. This is the fundus picture of right eye. You can see that the media is clear. The disc is normal in size, shape, and color. CD ratio is 0.3 with healthy neuroretinal rim. There are a few new vessels noted at the upper part of the disc. AV ratio is 1:3 with arterial narrowing, and AV crossing changes are also seen. Now coming to the macular area, there are several microaneurysms and hard exudates and dot hemorrhages at the fovea and around that area, and multiple dot and blot hemorrhages are scattered all over the macula and along the arcades. There is a pre-retinal hemorrhage present along the infratemporal arcade that is located within the arcade, and then there is another pre-retinal hemorrhage, larger pre-retinal hemorrhage that is noted along the infratemporal arcade outside the arcade in the inferior quadrant. And also there are several dot and blot hemorrhages noted in the periphery in the inferior caudal. Now coming to the fundus fluorescent angiography, the image was taken at 19 seconds. This is in the early venous space. We can see that there is the laminar flow has started. Now in this we can see the area of, there is an area of hyperfluorescence that is corresponding to the area of the pre-retinal hemorrhage that we saw in the fundus picture. So it is suggestive of blocked fluorescence. Then there are multiple hyperfluorescent dots noted along the supratemporal arcade that we can see are increasing in intensity and size as we move forward along the subsequent FFP images, which are suggestive of microaneurysmal leaks. And
can I interrupt you here 1 second?
yes, sir.
So you have a case here where we can see the pre-retinal hemorrhages. There is a neovascularization on the disc. Very well, a clear-cut case of proliferative diabetic retinopathy. So why would you have done an angiography in this case? Or I'll reframe the question: what are the indications of doing fluorescent angiography in such a case?
So to look for neovascularization elsewhere, the exact area of leaks.
Yeah. So you want to reconfirm your new vessels, whether it is NVD or NVE. What else could be the reason? Anybody can join. It is not to just Dr. Netra, Dr. Ashwari.
Anybody can join. Yeah, please.
Unexplained vision loss.
Unexplained vision loss in diabetic retinopathy.
Yeah, so first thing is unexplained visual loss. How will you look at that, Dr. Ashwari?
Foveal avascular zone will be enlarged.
Yeah, macular ischemia. What are the signs of macular ischemia on angiography?
Enlargement of epithelial.
Yeah, more than enlarged.
Capillary.
Yeah.
Does
CNP
it
cap.
mark?
1% at a time. Ashwari? So enlargement, or it can be a distortion. More often it is a distortion of the FSZ rather than enlargement, because it is a nearly circular pattern which is distorted many times. It might be the central non-perfused area may be encroaching onto the normally what we expect as perfused. Into that area, if it is encroaching in a triangular or wedge-shaped pattern, we think it is a macular ischemia. So distortion of the normal FSZ pattern, enlargement, and what else can be there? Sometimes vessels can be seen growing into the FSZ also. That is also actually a sign of macular ischemia. If you see vessels encroaching into the what we expect as FSZ. So that also can be a sign of macular ischemia. So can you comment on your angiogram? Are you able to? Which phase will you use, Doctor? Who was presenting?
Dr. Amrita.
Dr. Amrita. In your angiogram, you didn't comment about the FSZ, I think. Did you look at it? So it is important you look at it in the fluorescent angiogram. Early phases, you have to look at the AV phase where it is maximum vessels are brightest, maybe the ideal time to look for a macular ischemia. So you have to comment about the FSZ at that point of time. So especially in a case, one of the indication could be to look for a macular ischemia. Any other condition and indication could be there in this particular case other than macular ischemia?
To find to find the areas of neovascularization.
No, that is not very important. Of course, it will help. Once you do an FA, you will come to know where the neovascularization are exactly, CNP areas and all. But other than that, as such, you want to do an angiography because it's already evident there is new vessel, there is bleeding. So everything is already evident. You will just go ahead and do a PRP as well without doing an angiography. So why would you have done an angiography in that case?
To find the macular edema if it's diffuse or focal.
Yeah, it might give an idea of macular edema, but more than that. So it could be something else. something mimicking diabetic retinopathy. If you have an asymmetric picture, if this eye is having bleeding, other eye is not having any, it is only showing a mild NPDR or a moderate NPDR or a no PDR at all, I mean no diabetic retinopathy at all in the other eye, or you have a rubeosis with a normal intraocular pressure, all those conditions might, it could be a mimicker of PDR. What else it could be?
Ocular ischemic syndrome.
Ocular ischemic syndrome. If it is an asymmetric, only this eye is showing all this picture, other eye is normal, then you might do an angiography to just what will you look for on the FA. So that should be your first comment. Whenever you read a diabetic retinopathy fluorescent angiography, your first comment should be that. What is that?
Arm retinal time.
Arm retina time. So you should start actually with that is a before all your thing. You should mention the what was the arm retina time. So arm retina time and FAZ are two things which you should compulsorily comment when you interpret a angiography of diabetic retinopathy. So what was the arm retina time in this case? Maybe it was not done for that purpose, but you should always mention what is a normal arm retina time?
8 to 12 seconds. Sir.
Pardon?
8 to 12 seconds.
8 is 2, it will be 12 to 20, up to even sometimes it can go to 19 or 20 seconds also. Up to 20 seconds we can consider as normal. And it is, what is it a reflection of? Arm retina time is a reflection of? A patient's intact systemic circulation, starting from the venous circulation to the arterial, through the heart, to the carotids, to the retina. The whole time is what we see as a, so it shows a normal systemic circulation. So arm retina time, when you do in a fluorescent angiography, what you are assessing is the normal intact systemic circulation of a patient. That gives an idea about the systemic well-being of the patient. So even if the heart is pumping weak, there is a carotid obstruction, there are many reasons where there can be a altered arm retina time. So that is very important. That till that point we get a idea of the patient's systemic status. Then comes the eye. So in the fluorescent angiography, rest of the things you look at the retinal circulation. But before that, till that time, it was the systemic circulation what that we were looking at. Okay, so these two things are very important.
Can I add something to that?
Yes, Dr. Rohan, please.
Yeah. So very rightly, like Dr. Prakash has mentioned, so if there is obvious new vascularization like you have in your case and an obvious pre-retinal bleed, then angiography is not compulsory. So you can go ahead and treat, like Dr. Prakash said, you can go ahead and treat with pan-retinal photocoagulation. So in today's era, probably if your visual acuity does not match the clinical picture, then you would go in to look for the macular ischemia. And someone had mentioned macular edema. So in today's era again, by 90D, if you have a suspicion of macular edema, then better to do an OCT and confirm whether it is center involving or non-center involving. Because if it is non-center involving, if it is center involving, then again the treatment directly goes on to an anti-VEGF therapy as primary therapy, and you don't need an angiography. But yes, if it is no edema or a non-center involving edema, then you can do an angiography and look for your extrafoveal focal leaks, and the fluorescein angiography will help you in planning laser for that. And secondly, like Dr. Prakash mentioned, ocular ischemic syndrome, again that is an important differential diagnosis. So one thing he mentioned is the arm retina circulation time. And the other thing you must look out for is that mostly in ocular ischemic syndrome, what you see is a mid-peripheral ischemia. So that starts as mid-peripheral microaneurysms, and not like this case in which you have microaneurysm right at the posterior pole itself. Although long-standing it can have everywhere, but it starts generally as a mid-peripheral ischemia. And especially in asymmetric cases, it becomes an important differential diagnosis. So I think you can go ahead, or if any of you have any queries regarding angiography for a diabetic patient. Okay, so go ahead with the next case. I think Dr. Gopal is saying we have too many cases.
Yes.
Yeah.
No, so what I think we should also go into is reading of this particular angiogram. Where is the block fluorescence? Where is the leaking? Where is the staining? Where is the window defect? So that can also come in, because I think, okay.
Yeah, got the point, Gopal.
Moving on to the next case. This is a clinical picture of the left eye. Disc is normal size shape, margins well defined. vessels over the disc appear normal. AV ratio 2:3. There is a yellowish, well-defined lesions within 500 microns from the center of the from the fovea, suggestive of hard exudates. There are multiple dot, blot, and flame-shaped hemorrhages. Moving on to the FFA. This is a fundus fluorescence angiography of the left eye at 32 seconds, showing multiple hyperfluorescent lesions.
Are there only hyperfluorescent?
Some CNP areas, capillary non-perfusion areas are there, sir.
Why do you say they are CNP areas? Can they be block fluorescence due to the where can you show the block fluorescence? I mean the hyperfluorescent areas? Can you say marker or cursor? Yeah, that is fine. Which is the one which you are mentioning?
Sir. This one, sir.
This is hypoperfusion according to you.
Can you show once more? Yeah, you can use a pointer maybe. It may be better to use a pointer.
Mark the hypofluorescent areas.
Sir, I'm trying to use a pointer. I'm not able.
Okay, you can use a cursor, no problem.
Netra, can you just show hypofluorescent?
Yeah, we can take help from Netra.
I think Netra is presenting all the cases.
Yeah, I understood.
And so I don't think Gargi will be able to show.
So Netra, please show us.
This is the central area which you are showing, which Dr. Gopal already told you will be normally more hypofluorescent. What about the abnormal hypofluorescent areas? So you see, there are not many in this, but just near the supratemporal vessel. Yeah, just go up.
Just above the macula on the right
above
side.
The macula where you have these focal microaneurysms.
Exactly. Yeah.
Just temporal to
it. Temporal to that.
Temporal to it.
There.
Yeah. So are these capillary non-perfusion or are they something else?
Dr. Gargi, are they?
This capillary non-perfusion, sir.
Why do you say so?
So whenever you have confusion, go back to your fundus image.
Exactly. You have to compare with your, is there anything to, other thing could be a block fluorescent due to that hard X-ray. So you have to just see whether they are matching or not.
Okay, sir.
So go back and compare. That's the best way to look at it. And if you have already one of your major vessels blocked, then you will think more of the hard X-ray blocking. Now, since vessels are not blocked, maybe it could be a capillary non-perfusion.
Yeah. Okay, go ahead.
Okay, go ahead.
So this is a late venous phase, so showing the leakage of the hyperfluorescent area suggestive of macular edema.
So
now you had a early hyperfluorescence, and in the late phases that increased in size and intensity.
Size and intensity.
So
sir.
that means it is a leak. So that is probably from the microaneurysm.
Yes, sir.
Okay, so that is.
Okay, so I have one more additional feature here. Just go back to your previous slide. Now just see clearly where your microaneurysms are. Again, where you mark those hypospots, mostly are concentrated along this vessel. Okay, now you go to your next slide. So now again, this area is becoming more hyper because like we said, probably they're leaking from the microaneurysms. But aren't there other areas also which are becoming hyper, which lack the microaneurysms?
Yes, sir. The superotemporally, sir.
Supratemporally, then if you come closer to the fovea, foveal center, just supratemporal to the foveal center, again, you see this area is becoming hyper. No, just below this. Yes, this area. Okay, so the leakage is not just from the microaneurysms,
Capillary leakage also there, sir.
Yeah, so there is diffuse, some leakage, some areas of diffuse leakage from the generalized capillary bed as well. So both types of leakage are happening here. Focal as well as some amount of diffuse leakage. Go ahead.
This is the same picture, sir, showing all three phases.
Do you know the visual acuity of this patient?
No, sir.
So, any clinical scenario when we are actually seeing, we should not see anything just in isolation. So you should have the visual acuity, fundus, this, then only you can make a better judgment of what next is to be done. Okay, go ahead. Next angiogram maybe.
Moving on to the third case. This is the clinical picture of the right eye showing clear media. Disc appears normal in size and shape, margins well defined with a cup disc ratio of 0.4. Superiorly, the artery is showing narrowing with a segmental arteriolar narrowing, which is typical of a box scarring. And the superior retina appears to be infarcted. Superiorly, the vein appears to be dilated and tortuous. The AV ratio superiorly seems to be 1:4. Inferiorly, it appears to be normal. Drusen's can be seen as a clump that is just superior along the superior arcade, just inferior to the superior arcade. And multiple microaneurysms are seen scattered over the posterior fold. Flame-shaped hemorrhages and soft exudates can be seen inferiorly. And moving on to the fundus fluorescein angiography at 36 seconds. There is delayed filling in the artery despite the filling of the veins. And microaneurysm, there is hyperfluorescent areas that can be seen, which could be suggestive of the microaneurysms, as we have seen in the clinical picture. And same, the delay in the filling is noted as the phases are getting progressed. At around 4 minutes, again, at this phase also, at this phase, the artery has got filled, and this FFA would therefore be suggestive of superior transretinal artery occlusion with a combined possibility of a diabetic retinopathy.
So what are the abnormal hypos you see in this case? Abnormal hyperfluorescence.
In superiorly, there could be a little bit of hypofluorescence, which is suggestive of an infarcted retina.
Now, normally you would have expected retinal arteriole to be hyperfluorescent with filling of fluorescein and so veins also by this time. So here, what you're seeing is a filling defect along the superior retinal arteriole, isn't it?
Yes, sir.
And what about the venous system? Is it looking normal?
Slightly tortuous and dilated in the superiorly, sir.
What
Go
about
back to individual frame?
Go back.
Yeah.
Here, stop here. Next one, or here, fine.
There is hypofluorescence.
You have still earlier films in this? Still early?
This one is.
Okay, okay, stop here. So what is the problem with venous circulation also here?
Compared to the superior, the inferior is hypofluorescence.
Now the superior venous system is not filling properly, is it not?
Yes, sir.
The area drained by the superior arteriole is not filling. So the venous system, there is also a venous delay. So what are the findings you expect in a retinal artery occlusion? You should look at the early phases, which in this case is missing. We should have looked at the early phases properly. What all will you see in a central retinal artery occlusion? What do you expect if you had an early picture?
Delay in the.
This is already a venous phase. We have missed the AV and the early phases, choroidal phase. So what would you expect? What would you expect in a choroidal phase? What would you look for in a choroidal phase rather? In a suspected case of central retinal artery, where we clinically itself it is obvious you have the retinal whitening, you know it's a branch retinal artery. So in FFA, what will you specifically look in the choroidal phase? Dr. Ashwari, can you help? Okay. Ashwati, Dr. Samisha, somebody can help. What will you, in a case of when you do an FFA, what will you specifically look for?
Choroidal fluorescent perfusion.
Yeah, the
Combined ciliary artery occlusion.
combined ciliary artery or ophthalmic artery occlusion. So you will look at the choroidal filling if it is normal, or if sometimes it may be partly filled, medial side it may be filled, lateral side it may not be filled. So suggest there is a ciliary artery occlusion along with it, or an ophthalmic artery occlusion. And also you will look at the arm retina time. So in the early arterial phase, what are the signs of retinal artery occlusion? What is leading edge of the dye?
Leading edge can be seen.
Yeah, leading edge of the dye may be seen. What is it? Can you just explain, Sumisha?
Because of delayed filling of the dye, we can see the leading edge. Normally, there is no leading edge can be seen.
Yeah, normally the arterial filling is so quick, you don't see an area in the arteriole which is not filled and filled. So in a case of central retinal artery occlusion or a branch retinal artery occlusion, there will be an area which is not filled, and there will be an area, proximal area will be filled, whereas the distal area won't be filled. So the partition can be seen. That is known as the leading edge of the dye. That will be typical of a sluggish arterial circulation.
So here you are trying to say that this is a superior branch retinal artery occlusion, and
Yes, sir.
see so little flow is there in the artery. So how did the veins get filled? Where did the dye come into the veins from? Like Dr. Prakash said, you should have shown us the early phases also, because in early phases, probably the veins would also not have been filled, and you would have seen the cattle trucking maybe better or lack of flow. And the capillary non-perfusion area superiorly also might have been the contrast would have been better, highlighted better. But okay, let's see now if it's in this phase, how did the veins get the flow? Where is the dye coming in the veins from? Anyone?
Look carefully at the angiogram, you will get the answer. Another picture is there. Next slide, where disc is shown. Next one. Yeah, you can stop here.
See, even the superior vein, which
branch.
was, yeah.
Yeah, the superior branch is completely blocked arteriole. So how did the vein get the blood?
So there was a delayed filling also. You see in the earlier phase, the superior vein also, the top part was not filling, only the bottom part was filling. Okay, so that means there is some amount of collateral circulation happening over there, and the veins are getting blood from the other half of the retina.
Yeah.
Had it been a complete CRAO, then you would not have seen this sort of a picture.
And also probably there's a ciliary artery. So probably inferior retina macula is perfused, even though the superior branch is blocked.
Okay, so yeah, so there is some collateral formation also and a ciliary artery. Okay, go ahead. Go ahead.
What is the abnormal hyper in that, Dr. Netra was talking?
Artifacts, sir.
It's an artifact. What is abnormal hyper? Other than artifact, and on the arteriole is, what is that? What is that hyper? Just go back, clinical picture, show the clinical picture. Only narrowed vessel. Probably it is a staining of the emboli or the thrombus inside the arteriole. I'm not sure. Maybe that could be the reason. Okay, it is not clinically visible, that's why.
Yeah. So again, if in a definite case, maybe an angiography is not indicated, but if you are suspecting more than just an retinal artery occlusion, along with that, if you're suspecting a choroidal infarct, combined sort of occlusion, then maybe you can go ahead. But yes, for teaching purpose, it's fine. Yeah. Go ahead. Next case.
Moving on to the next case, there's a fundus photo of the left eye showing a normal disc with normal size and color with a CDR of 0.3, healthy neuroretinal rim with vessels normal with AV ratio of close to 3, and it's showing a lesion of around 1 disc 1 dd size, around 2 dd temporal to the temporal margin of the disc with mild hemorrhage. Moving on to the fundus fluorescein angiography. So this is a fundus fluorescein angiography taken in the taken at 25.2 seconds in the arterial phase and shows an area of hypofluorescence around 1 dd in size. And in the later phases, it shows an area of, this is FFA done in the AV phase. And this shows an area of hyperfluorescence with an area of hypofluorescence in the center. In the later phases, the hyperfluorescence increases in size and in intensity, suggestive of leaking.
So what is your diagnosis?
Probably a classic CNVM.
What is the age of the patient? Well, then that will tell you something more. It's a CNVM, but what is the etiology of the CNVM? Maybe you could get from that.
What is the blocked fluorescence due to? The hypo that you showed in the early phase? But when you compare with the color photo, it is not matching, is it not? Is it matching? Only there are 2 small areas of hemorrhages, but your hypo is much larger than that. Previous picture. Yeah, here. So it need not be just hemorrhage alone. It could be the exudation from the membrane as well as the fibrovascular tissue, the fibrous tissue itself. Some amount of scarring may be happening. So that also can block your choroidal fluorescence.
Are you seeing an abnormal hyper in this frame itself?
Yes, sir.
So it is very important to pick it up at this stage itself, because this choroidal neovascular membrane will have a lacy, see here also it's sort of a lacy hyperfluorescence from the very early phases. Yeah, go ahead. So why are you saying this is a choroidal neovascular membrane?
So because associated with hemorrhages, and like when we consider the age of the patient.
So
you didn't tell the age, you were only looking at the angiogram. So based on angiogram alone, why do you tell it is angiogram itself? It is a very typical of CNVM. So why do you tell?
Starting in the early phases.
Yeah, there is a early hyperfluorescence lacy pattern which is leaking in the late phase. So that is typical of a choroidal neovascular membrane. That too, type 2 choroidal neovascular or classic.
So just to go a step further, just show the next image. So like Dr. Prakash said, and what I was also saying earlier, that this is what we have typically been taught, that early lacy fluorescence increasing in time with associated hemorrhage should be a choroidal neovascular membrane. But choroidal neovascular membrane, what does it mean? It means some new vessels. Are you seeing some network of vessels here? So it's difficult to pick up in an angiogram. Why is it difficult to pick up in an angiogram? That individual network of vessels? Because if you were able to see... Sorry?
Yeah, you are correct. You can tell that.
Yeah.
Because of all the vessels are leaking, there's increased hyperfluorescence masking all the...
So the basic fact what Dr. Gopal mentioned is that this is a leaky dye, and what we are trying to study here is wherever there is the breakdown of the blood retinal barrier, and these abnormal new vessels have a abnormal barrier and they will leak too much. So all this dye is getting mixed up and you're not getting the individual vessels. But from our clinical impression, we know that these are new vessels there, and that is why we've said. But if you want to delineate it better, is there any other investigation available today where it will show you the individual network of vessels? Okay, one is ICG. One ICG, yes, it is less leaky. You may get the individual vessels, but the brightness may be a little less, and sometimes you may miss it. Any other investigation?
Dr. Ashwari?
OCT angiography.
Yeah,
Yes.
OCT angiography. So
Okay, so OCT angiography now 100% has confirmed us when it's most of the time shows us these individual linear or sort of these curved corkscrew like vessels, definitely showing us that these are new vessels there lying which are causing this problem. So what is the level of these new vessels? From this angiogram, what would you presume it to be most likely?
Sub-RP.
Sub-RP.
Dr. Ashwadi? Dr. Rohan is asking what is the level of that.
You just defined this as a classic choroidal neovascular membrane or the occult choroidal neovascular membrane?
Classic choroidal neovascular membrane.
Okay, so then what is the level?
Subretinal.
Retinal. Subretinal.
Okay, so because this is just beneath the retina, you are well able to appreciate this hyperfluorescence, and it is a classic membrane. So if you do an OCT, mostly the membrane would be in the subretinal space.
Subretinal space.
So an occult one, the abnormal hyperfluorescence would not be so well appreciable. It may be just a late leakage or a punctate sort of leakage, and you won't get this well-defined patch. So that would be a type 1 or a deeper membrane. Okay, go ahead.
So what is type 3 membrane, Dr. Sumisha? Or Dr. Ashwati? Somebody can answer. Type 3? For completion's sake, we talked about type 1, type 2. So what is type 3?
Retinal.
Come on, Sumisha. You're correct.
Retinal angiomatous.
Yeah, RAP or retinal angiomatous proliferans. Okay, continue. It's an intraretinal neovascularization.
Go ahead, next case.
Next.
Moving on to the next case. This is a fundus fluorescein angiography of the left eye.
I'm seeing only color photo.
Oh, sorry, I'm sorry. It is a fundus picture of the left eye. The disc is normal in size, shape, and color. CD ratio is about 0.3. AV ratio is 2:3. It appears normal. There is a there's a large SND at the foveal area, about 2 disc diameters into 2 disc diameters in size, which is located about 1 disc diameter temporal to the temporal margin of the fovea. And coming to the fluorescent.
Other than that, other than this detachment, what else? You said neurosensory detachment, right?
Yes, sir.
Yeah. Other than that, some other things also.
There are a few drusens located below the sensory detachment.
So yeah, they are drusenoid sort of structures, but you can just, for description sake, because we don't know again other features about the patient at present, you can just say that these are yellowish or hypopigmented spots which appear to be a little deeper or at the level of the RP, because you can clearly see some of the vessels over it. Yeah. So retinal pigment epithelial changes or maybe drusenoid changes. Okay, go ahead.
Okay, this is the early venous phase of Fundus Fluorescein Angiography. We can see hyperfluorescent area is just superior to the fovea, and the area of hyperfluorescence.
You can give a small description also. What is the what kind of hyperfluorescence? shape or something. Some point areas, no? Pinpoint areas of hyperfluorescence.
Pinpoint areas of hyperfluorescence superior to the fovea.
Yeah.
And when we come to the next, when we come to this is the mid-venous phase, we can see that the pinpoint areas have increased in intensity and size. And moving forward, and in the late phases, we can see that there's a focal area of hyperfluorescent leakage that has taken up the shape of a smokestack pattern, which is suggestive of a central serous retinopathy.
Any other pooling here?
I'm sorry, sir.
Any other abnormal hyperfluorescence here?
Above the area of the focal leakage, there are some other pinpoint leakages, sir.
So I think below the fovea here, I think there is some amount of abnormal below some amount of, maybe it's in the photograph, or it appears like some amount of dye has pooled in this area in the late phase also. So I don't know if you can appreciate. Dr. Prakash, do you think
Yeah, even I think so. There is maybe a little later phases would have helped us.
Helped us better.
There might be a little pooling there.
So actually we are seeing 3 hyper here. One, you said those punctate dots. Second, you said that leakage, which is increasing with time and which is becoming your smokestack. And third, what we feel is that subtle hyper below, which is the pooling. So can you try to explain how these 3 are different and what are they due to?
A pathologic correlation.
Okay, sir. The smokestack pattern, it is the leakage at the level of the artery, and we can see that the appearance is increasing in intensity and size because the fluid is actually more turbid than the dye, so the dye moves up, and that's why we see the particular pattern of increase in size and intensity.
Okay, so you basically see fluorescein angiography is a study of how the dye behaves with the outer and the inner barrier. So here we are mainly concerned about what is happening to the outer barrier. So like you rightly said, it is the RP level at the leak. So there is some rip there, some small micro rip or something, which is allowing the dye to come into the subretinal space from that pinpoint area. So that is the area of leak in the outer barrier. What about these other pink punctate points? So some of them may be just RP defects, window defects sort of appearance. And some of them again are increasing in intensity also. So they also might be other associated small leaks. So they are just some of the chronic RP changes happening there with with active leaks and one major leak. And then the pooling is just the gentle little amount of dye which is mixing up with the subretinal fluid and causing the late hyperfluorescence. So, Dr. Prakash, you'd like to add something?
Yeah, what else could be your differential diagnosis in such an angiographic picture? You are not given us any clinical scenario. So, suppose this patient has some pain also in that eye.
Posterior scleritis.
Yeah, posterior scleritis also could be a differential diagnosis in such a case. Pinpoint hyperfluorescence increasing. One area may be slightly high. So what other investigation you will add on to it to confirm your diagnosis if you are suspecting posterior scleritis? Pardon?
B scan, sir.
Yeah, B scan. What will you see?
The choroidal thickening, the RCS thickening.
Not just RCS thickening, something else typical of posterior scleritis on B scan?
T sign.
T sign, yeah.
You see, even in CSC, the choroid can be a little thick, although yes, in posterior scleritis it will be much thicker, but it can be. But T sign is the hallmark typical of fasciitis. Okay.
Okay, because it is very important you differentiate, because one treatment for one can worsen the other disease. So it's very important you differentiate these two. Can mimic also. Okay, next.
Moving on to the next case, it is a clinical picture of the right eye. Disc normal in size shape, margins well defined, cup disc ratio 0.3, vessels over the disc normal, vessel ratio 2:3. There is a pre-retinal hemorrhage inferior to the disc around the inferotemporal arcade, around 2 disc diameter away from the disc. There is one fibrovascular membrane around the superiotemporal arcade, 3 disc diameter away from the disc. There are multiple dot and dot hemorrhages. Moving on to the FFA.
Some hard exudates also.
Yes, sir. Hard exudates.
Is there any abnormal vessels in?
There is a fibrovascular membrane, sir, at the superiotemporal arcade. There are the abnormal vessels.
Yeah, you can see the abnormal feeder vessels also feeding that fibrovascular membrane. Okay. Torches.
So this is fundus fluorescein angiography of the left eye. It's a arterial phase.
The right eye. Yeah.
Right eye. Taken at 50 seconds. Arterial phase is there. As arteries are filled, there are multiple hyperfluorescence areas. Which are increasing in size and intensity in the mid-venous phase. This is late venous phase. There is a increase. There is profuse increase in intensity and profuse leakage with increased size and intensity, suggestive of neovascularization. With the block fluorescence inferotemporal arcade suggests corresponding to the pre-retinal hemorrhage.
Okay, can you go back to your second, maybe one more here. Yeah, also fine here. What is the time of this frame?
50 seconds, sir.
50 seconds, okay. Next one. Okay,
this is the next.
Yeah.
59 seconds.
Okay. So looks like there is a delay in venous filling, is it not?
Yes, sir.
What is AV transit time? Arteriovenous transit time. What does it indicate?
AV transit time 12 seconds.
That is arm to retina, no?
Sorry.
AV transit, what does it? Ashwati, can you? Somebody can tell what is AV transit time and what does it represent?
If it's more than 30 seconds, then it's abnormal.
No, not 30 seconds. AV transit time is first the time taken by, it actually represents the retinal circulation. In arm retina time, we are talking about the systemic circulation, whereas in AV transit time, we are looking at the retinal circulation, the speed of retinal circulation. So that can be delayed in diseases like diabetic retinopathy, venous occlusions, where there is a delay in retinal circulation. So you are looking at the time taken by the first fluorescent dye to complete the retinal circulation through the retinal arteriole, through the capillary, and back to the. So usually look at the disc margin when the dye first appears in the retinal arteriole at the disc, and corresponding vein when it first appears. So that time between that, those two time is called the time difference between the first fluorescent dye to appear at the retinal arteriole at the disc border, and then it come back to the corresponding vein. So for example, if you take the superior vessel here, so the dye when it reaches the arteriole, that happens within, you cannot see it first appearing at the disc border, but at the venous border you can make out when it appears, because venous location is slightly slower. So that time, that is usually 2 to 4 seconds, it does not take much time. So if there is a delay in that, then that is called a prolonged AV transit. So that shows there is some circulatory problem, like as in diabetic retinopathy due to capillary ischemia, or many other reasons, or it could be a venous occlusion. So all these things cause a delay in the AV transit. So that tells there is a lot of ischemic process that actually amounts to the ischemia happening to the retina. That's why you have such a large amount of new vessels in this retina, because there is a lot of sluggishness in circulation inside the retina. So that explains your, other than the capillary non-perfusion, of course, you have to look for capillary non-perfusion also, which will be seen better in the peripheral films. If you have taken peripheral pictures along with this, if you had shown peripheral pictures along this, you would have seen a lot of areas of capillary non-perfusion. So what we have to look at is it an artifact? All those hyperfluorescence that you see, is it an artifact or is it new vessel? All those are new vessel. So when there is a delay in AV, there is a prolonged AV transit time, as well as there is delay, lot of capillary non-perfusion area, there is a large amount of ischemia going on in this side. So generally prognosis is very poor for this kind of eyes.
In this frame itself, nasal to the disc, can you point out any abnormal hypofluorescence, abnormal? So what are these areas? What is this hypofluorescence due to?
CN areas, sir.
Okay, so now this is very clear that this is capillary non-perfusion. I don't even have to see the fundus photograph. Why? Because see, it is very nicely bordered by those vessels. That complete area is hypo, and the grayness is not black, jet black. So generally in capillary non-perfusion, again, it will be bordered by vessels, demarcated areas, and it's not as black many times as compared to the block fluorescence. But yes, always a good idea to compare it with the fundus photograph. Okay, go ahead.
Moving on to the next case, this is the clinical picture of the left eye, showing clear media with a pale retina, with the disc margins are blurred and arteries are narrowed, with the blood vessels that are towards the macula are appearing to be sludging, with there is a break in the blood column, and cherry red spot is seen.
In a common question which is asked sometimes in exam is what is the reason for the cherry red spot?
Cherry red spot is because due to this arterial occlusion, the retina could be edematous. So that can cause the perimacular tissue to be translucent while the fovea will be maintaining its normal color.
No, perimacular area is not translucent.
Yes.
But why is it not happening at the center?
Fovea will be remaining.
So why is it happening in the perimacular? What is the difference in the anatomy between the center and the adjacent areas?
Ganglion cell layer is absent.
Okay, so yeah, and multiple layers are present just around it. So those are the areas where you are getting the opaqueness or the translucency, but not in the center. Okay, go ahead.
Moving on to the fundus fluorescein angiography at 23 seconds. Here the arteries have not filled up, and as the phases are progressing, non-perfusion areas are also noted. And at 3 minutes, also the arteries have not yet filled up.
Can you go back? Just go back. There you can see the what we call as a leading edge of the eye. So just go back to your first picture. So what is the abnormal fluorescence here? Is it hypo or a hyper? One more picture
One
back.
is the
one more. Is there one more picture before this? I thought there is one more.
No, sir.
No, this is the first one. Okay, yes. Okay. What is the abnormal fluorescence here?
One is there is hyperfluorescence that is occurring in the as we progress in the stages. We can see it in the around the disc, and the
hyper is abnormal or the hypo is abnormal here? See, don't get confused. Hypo means whatever we are expected to see as hyper. If it is not seen, then it is a hypo only. So the arterioles and venules are not filled. So that is not abnormal hypo.
Yeah. Not abnormal hypo.
And background choroid, what about the background choroid?
Hypofluorescence.
Are you getting some flush?
Patchy choroidal flushes.
Yeah, choroidal fluorescence seems to be normal. Is it not? That's why you are getting the blood vessels, the hypo of the blood vessels are standing out because of the background of the choroidal fluorescence. Otherwise, you would be seeing everything black. So there is a choroidal fluorescence. So you saw a cherry red spot also. So that means probably the ophthalmic artery is not involved. It's basically a central retinal artery. So the retinal vessels are standing out hypo because the background is hyper. That hyper is due to the choroid. So choroid is normally filling here. So that is why is it important? Why you want this phase is very important. You want to know why is it important from a management point of view. Why is it important that you look at the choroidal fluorescence? You make an assessment. Is a choroid or is a ciliary circle, ciliary artery involved or not? What is the importance?
Which artery is involved, the central retinal artery or the posterior?
Yeah, why is it? Why is it? Why is it important? See, because there is a large amount of patients who are probably the cause could be a giant cell arteritis. So that is something preventable because after 2 weeks, patient will come with other eye also, sometimes CRI and so it is very important you recognize if the ophthalmic artery also is involved, you have to think of more of giant cell arteritis also. You have to evaluate for ESR and CRP and all those stuff for GSEA or clinical evaluation also. So that might, because CRIO as such, we are not going to have any major treatment for CRIO unless it, so the importance is to identify if there is a GCA present, giant cell arteritis that is present. If that is present, you have to prevent that happening in the other eye. Okay, so that is the importance of angiography here. Angiography is to specifically look into certain etiological questions you have in your mind. Next. Here you can see some arteriole filling and not filling. That's a leading edge, what we call as a leading edge of the eye. Yeah, you can go ahead with this case.
Moving on to the next case. This is a fundus photo of the right eye where disc margins are well defined, cup appreciated, well defined. There's a well defined lesion of about 1 dd away from the temporal disc margin, measuring about 3 disc diameter to 3 disc diameter in size. Moving on to the FFA, taken at 31.4 seconds, showing the early venous phase. There's a well-defined hyperfluorescent area with an area of hypofluorescence in the center. And also there's an area of hyperfluorescence along the inferior arcade, along the vessels.
So again, describe the infratemporal area a little more better in terms of shape. Like
infratemporal area is diffuse
pattern.
It's a diffuse, showing a diffuse pattern of hyperfluorescence with intermittent focal leaks.
So again, some punctate points in that.
Punctate points, yes.
And the hyperfluorescence here is much more than what the other one you are seeing all around in the large lesion. Yeah. Okay. So that itself will tell you that there is a difference. Okay, go ahead.
This is a FA showing the venous phase where the area of hyperfluorescence is further increasing compared to the previous picture. And the leak in the vessel is also increasing in size and in intensity, whereas this hyperfluorescence is not increasing in size, but only increasing in intensity.
And the shape is constant. One is having a constant shape and with slightly increasing hyperfluorescence. Yeah. So that is a pooling and the other one. So this is a typical case where it
can, and this is suggestive for leaking. So this could be a case of an occult choroidal neovascular membrane.
Any hypo in this?
Sure, sir.
Yeah, this area. So what is this?
Blocked fluorescence because of a submacular bleed.
Just show the fundus.
It could be some fibrin or some exudate inside that PED.
Okay,
that's
so
blocking.
Yeah, so something inside the PED. So you should see it more carefully, probably with a 90D or something, you'll probably get it. Okay. So again, now the same question, why did you make it an occult PED, occult CNVM? Previous
It
one,
occurs during the later phases, sir, not the leakage doesn't occur in the early phase, and it occurs towards the later phases of the fluorescein angiography.
It didn't show us the early pictures again. And early pictures would have arterial phase would have given us a better idea. Anyway, this is typical of a occult membrane with a
so
large
again, those
fibrous.
punctate nature, and rather than having that large, well-defined patch, that tells you that it is an occult. And like if you had the early phases, it might have been missing definitely in that, and slowly it would have come up. So anything abnormal about this PED? Anything about the shape of the PED or anything which tells you more about the case? Have you seen many types of PEDs? Some might be different from this. Go. So actually, this is a notched PED. See the shape itself, it's having convolutions, and this particular area where your occult membrane which you are pointing out, that is probably the notch in the PED. So these notched PEDs are more likely to have choroidal neovascular membranes, whereas something which would have been more uniform, well defined would probably more have been a serous PED. So the other part of the PED is mostly filled with fluid, and only this bottom part is the choroidal neovascular membrane, which would have a surrounding little amount of bleed.
What will you see if you do an OCT along that area?
Where you feel there is an occult membrane, if you take an OCT cut through that area, what will you see?
Fluid.
Fluid the upper, fluid where? Which layer? PED has, yeah, so the entire PED would have sub-RP fluid anyway. Anything more in this area?
Thumb size.
Some material may be seen.
Irregular elevation with.
Usually you see, as Dr. Rohan told, there will be a notch there, as well as you will see some material sticking underneath the PED there, that area, which could represent a BVN or a polyp.
So some abnormal subretinal hyperreflectivity there, which will tell you that it's not just fluid, something else also there. Yeah, go ahead.
It's about important to have a pathology FFA to OCT correlation. Whenever you see this kind, whenever you go back and see the OCT also along with these cases and correlate, so that one investigation will you to give you an idea about the other one. So if you do an OCT alone, you can predict about how the FFA will be like. So the OCT will tell you what will be the angiography without doing an invasive procedure. So that's why it is important to correlate always. Okay, next slide.
Moving to the next case. This is the fundus picture of the right eye. Disc is normal in size, shape, and color. CD ratio is about 0.3 with healthy neuroretinal width. The AV ratio appears normal 2:3. Now coming to the foveal area, there is a sensory neural detachment of about 1.5 disc diameter in size, located about 1 disc diameter temporal to the temporal margin of the disc at the fovea.
Are the other postgraduates convinced that there is a neurosensory detachment here?
Dr. Ashwadi, are you convinced?
No, sir.
Okay.
So you see, sometimes these just the fundus photographs can be misleading, and these are definitely 2D photographs. So better to do a slit lamp biomicroscopic examination. But here, yes, subtle, you can see maybe a few vessels seem to be a little elevated just around the fovea, and the grayness over there is more, the choroidal reflex is not coming as well as in the surrounding area, telling us, yes, maybe there might be some fluid. But little subtle. Okay, go ahead.
And there is yellowish lesion along the supratemporal arcade, about 1 disc diameter supratemporal to the fovea, and multiple yellow lesions noted along the infratemporal arcade, and one that is temporal to the SND. They have irregular margins. The yellowish lesion that is along the supratemporal arcade, it has a well-defined margin. Now coming to the fundus fluorescein angiography, this is arterial phase taken at 17 seconds. There's nothing much seen here. Moving on to the next. This is the mid-venous phase. There we can see a few hyperfluorescent dots noted along the supratemporal arcade. I'm sorry, one second. And one focal hyperfluorescent dot along the infratemporal arcade.
Just adjacent to that dot infratemporal arcade, also there are some small hypo patches. Can you appreciate those? Just for sake of completion and proper description, you should not miss findings, whether they may not have too much relevance, but still, can you see just adjacent to that focal point?
Yes, sir. Hypofluorescent areas, yes. Just
so keep everything in mind so that you know that you can find out what is the reason behind it.
Yes, sir.
Okay. Go ahead.
Now moving to the next phase. This is here we can see that the focal hyperfluorescent dot, it has increased in intensity and size, and it has taken up the appearance of an ink blot pattern, which is suggestive of CSR, whereas the other hyperfluorescent dot along the supratemporal arcade, it has increased a little in intensity, but size remains the same, which is suggestive of PED, and the smaller dots, they have taken up the stain, but they remain the same when it comes to, it has not increased in size or intensity. So they might be drusen's that have taken up the stain.
I say that they are not drusen. I say they are window defects. How can you support what I'm saying or contradict what I'm saying? Those small 3 dots.
They have ill-defined margins. So window defects will have well-defined margins.
Not necessary, and they are also not very ill-defined. I can make out. So to classify something as a window defect, what all phases will you have to look at?
We need to look at the early phases.
So show the early phase.
I think the choroidal phase is not this.
Okay, so we don't have a very early phase, but from the next one. This, yeah, so they are here in this phase as well. Then what else would you look at? So you also have to look at the late phase. So you see, a window defect will slowly fade away with time.
But
So
the choroidal phase and the margins will be distinct.
and then see the fundus. Is there something which might be something forming a window or not? So what is in the fundus? Go back to the fundus. So see, if you take this to be a case of CSC, then you can expect some pachyducin, but typical drusen you will not expect in many cases. So these might just be some RP changes there, and RP changes would look like some areas of atrophy would look like an window defect. Okay, so some of these may be just window defects, and one rightly you said that is a PED up there, and the lower one is a leak. And hypo, we also saw 3 small hypo spots along that leak. So either they are focal small areas of RP hyperpigmentation there, which are blocking the fluorescence, or maybe some fibrin deposition, which can be again blocking the fluorescence. And Dr. Prakash, you would like to add?
Yeah, I agree with your thing. It's very important to look at what is it a window defect or is it a staining of the drusen? So it's very important. So mostly these are window defects due to RP defects there.
You see drusen, you have to again see the clinical picture. Na? In CSC, the type of drusen which you might have most commonly would be just pachydrusen, maybe if at all. And those are, yes, some of them can be isolated ones, but you won't have those typical age-related ARMD type of drusen. Okay, go ahead. Next case. Next.
Moving on to the next case, this is a clinical picture of the left eye with a clear media, with the hemorrhages that can be seen over the disc. Vessels appear tortuous and dilated, with multiple cotton spool spots and flame-shaped hemorrhages. Moving on to the fundus fluorescein angiography at 23 seconds, there is delay in the filling, and that can be seen as the FFA is progressing. There is delay in the arteriovenous filling, and this leak can be noted as a result of the NV, new neovascularization over the disc. So this is suggestive of central retinal vein occlusion.
So what are the hypo that you are seeing in this? Are you seeing hypo? If at all seeing hypo, how do you explain those hypo?
Multiple, those are the multiple superficial hemorrhages, as well as
does the shape you have, does the shape look like superficial hemorrhage to you? Can you go back to your picture?
Yes, sir.
Just
as
hold
well
on.
As the, as well
just
as
come down. Just come back to yeah. So you have to look. You have to compare with your picture.
With the fundus photograph.
Yeah, it's very important. You compare whether you are seeing. This is not a very
or the CNP areas.
Exactly. So next, come back. Next one. Next one. Next one. Yeah, here. So here, what are you seeing? See, in the macular area and all, you don't have hemorrhages to explain that. Do you have? No. So that must be there within the vessels, well, in between the vessels.
CNP areas.
Yeah, so these are mostly capillary non-perfusion.
areas.
So if you just see this area above the superior arcade, this large area of capillary non-perfusion, can you point it out?
Yes, sir.
Can you show the CNP area there?
Yes, this just above the superior, this U-shaped.
Next
vessel,
one, next
superior
one, right
arcade, side. More temporal. Just below.
Yeah, down.
Okay. Yeah, so now you see, can you make out there are 2 hypos here? One is a slight graying and one is a dark blackish. Okay, so that is getting superimposed. So it's predominantly a capillary non-perfusion area, but on it there are some areas of extra blockage because of maybe some hemorrhages there or some of those cotton wool spots sort of feature there. And this double sort of thing is there in many of your patches.
So that means there's a blocked fluorescence on top of your capillary non-filling defect. So both the causes of hypo are seen here. Why is it important identifying CNP areas in CRVO?
To differentiate between the ischemic CRVO and the non-ischemic CRVO.
Yeah, if there are a lot of extensive CNP areas.
Like more than 10 disc areas, then it is ischemic CRVO.
The prognosis is poor. It is not actually differentiating the ischemic or the ischemic is basically dependent on the visual acuity, RAPD, etc. But fluorescent angiography contributes to that. It tells you there is a lot of ischemia going on. Prognosis is poor. Chance of NVG and VI are higher in these cases.
What is most common in CRVO? NVI or NVD or NVE? What would you more commonly expect in CRV? What type of neovascularization?
And yeah, neovascularization at the ankle.
So in the iris or at the angle, not in the
Angle.
posterior chamber. No? So here you were talking about NVD. Do you really think it is NVD?
With the disc leakage, there could be a possibility that there was neovascularization at the
Just
Is
show next.
neovascularization alone cause of disc leak? Next slide. Come to your next slide. Last slide. Yeah.
venous congestion.
Yeah, the venous congestion and edema in the disc itself will be a cause for
It will
leak.
cause-
So it need not be a neovascularization. Looks more like collateral flow.
Okay, you see, yeah, so some of the vessels itself are tortuous and maybe joining each other. So more of maybe some collateral formation, although the case is little fresh, but maybe just a long-standing case and the hemorrhages are still persisting. But like Dr. Prakash said, just the disc edema itself will cause this fuzzy margins. So I don't think there is a NVD happening here.
So in those cases, how will you look? How will you rule out NVD? Dr. Amarta? No, Dr. Lisa, who is? No, you have to clinically see. Clinical, look with the 78D lens, whether the lens vessels are elevated and are coming into the vitreous cavity. So that shows that's a NVD. Yeah, whereas a tortuous vessel will be well within the disc collaterals also. Okay, so you always have to just one imaging modality may not just help. You can do OCT or you can do a clinical examination. So it is always you have to approach it from clinical side also. Just not by looking at an imaging, you cannot completely tell many times. It's important to correlate.
Yeah, and an NVD would also leak much more profusely.
Yeah.
Yeah, go ahead.
And what are the other hyper present in this? Dr. Lisa?
Along the superior arcade, we can see hyperfluorescent pinpoint areas, sir.
Yeah. What are they?
Microaneurysms.
So in CRVO long-standing, you can have aneurysms, microaneurysms, or even secondary macroaneurysms developing. Many of them are not at capillary level. Even many of them are at the main vessel level, if you look carefully. So they may develop into macroaneurysms also. Venous side also you can see. Okay.
What is the cutoff for a macroaneurysm size-wise? What we generally take? How much size is a microaneurysm when it becomes detectable clinically, and what is the cutoff when we start saying that it's now a macroaneurysm? Generally 100 microns, more than 100 microns we take for a macroaneurysm, and microaneurysms would be clinically visible once they are larger than around 30 microns or so.
Another important thing is microaneurysm happen usually at the capillary level, whereas macroaneurysm, the retinal artery especially, happens of the second order branching, within the second order branching from the retinal arteriole. Whereas in CRVO, you can even see venous side large aneurysms developing because of the venous congestion. Okay.
Go ahead, go ahead. I think we'll take one last case.
Yeah, maybe Gopal.
Sir is not here.
Oh,
Sir
Gopal
has
is
for another
some other.
meeting,
Okay,
yeah.
okay.
So he said that 8:30.
Okay.
So
We should stop. Okay.
So that was an excellent session of fundus fluorescein angiography, going through different case scenarios, fundus pictures, discussing different possible questions that would be asked for the exam. Thanks a lot, Dr. Rohan, Dr. Prakash, for that excellent discussion, and also the postgraduates. Thank you very much. And next week, we'll be having a case-based discussion from Giridhar Eye Institute, and that would be proptosis by Dr. Marian. Thanks a lot.
Thank
you, Dr. Rehna. And thank you,
Thank
Gopal
you.
and Amarda team for excellently organizing this. Very useful for PGs, I think.
Yes.
Thank you very much. Thank you.
Thank you, Dr. Rohan, also.
Yeah, nice
taking
seeing you,
your
Dr. Prakash.
time.
Yeah, thank you very much. Okay.